Hope you're having a great day. He is Paul Gerard. I am Kevin Kelly. We are Gerard and Associates. Check us out at gerardassoc.com. This is the G&A Way podcast. Thanks for tuning in. Hey, Paul, it's been a little bit since we've done a podcast. How you doing?
It has. I'm doing well. You?
We took a little vacation, law practice, a lot of things going on, but it's great to be back at this with you.
Yeah.
All right, so today we're kicking off Traps for the Unwary EMS Provider series with the who was it? Clint Eastwood. Do you feel lucky, punk? And we're talking about the risk associated with the ALS downgrade to BLS calls and the need for the airtight documentation to support that critical decision. Paul, we're seeing a lot of this. It is a known unknown for a lot of EMS agencies. We've been going out, we've been doing the trial audits, and we see this, frankly, popping up, some holes in the Swiss cheese that we can hopefully help the EMS agency reduce.
Right. Yeah, we've been seeing it a lot more. For years we've been a regional QA company, and over the last year or so, we've reached out nationally and done some national advertising. So we're getting calls from around the country. And what's interesting is that we're seeing that some of the things that we see here is going on everywhere. In some cases, people do things a little bit differently, in other parts of the country. It's all actually pretty fun to watch and learn. But what I've noticed is that almost 100% of the time, pretty damn close to 100% of the time, when we talk to folks from all over, whether it's local or in other parts of the country, I raised the topic of whether their agency has a triage to BLS or a downgrade note policy. And the vast majority, in fact, almost 100% say either no or they have one, but it doesn't get enforced. So it's something we pay a lot of attention to when we do our quality improvement with the agencies that we work with. And it's a topic that we pretty much have to bring up with every agency we start with, because very few of them actually address this issue. So it's an important issue. So what is it? What's the downgrade note? What is the triage to BLS? And simply put, it's a bit of documentation from your ALS provider whenever they triage off the call to the BLS person. What we're seeing in practice is that you get a PB crew or a basic crew with a paramedic intercept or a tiered response or something, where the paramedic comes aboard. He determines that he's not needed in some fashion or capacity. And so that provider says to the BLS guy, you can handle this on the way to hospital, right? You don't need me, right? And the EMT says, yeah, okay, no problem. And so they kick it off. So what happens from there? Let's talk about what happens after that. After that, the EMT, the BLS crew, takes that patient to the hospital. They write up a BLS run report. The BLS run report goes to the QA program. We review the run report and we say, I can't believe the paramedics didn't ALS this guy. Based on the information from the BLS run report, there are clear indications that this patient should have received ALS. And now the question becomes for the paramedic, how come you didn't work this patient up? Now, again, continue that further downstream. You're our in-house counsel and EMS legal extraordinaire. There's a whole bunch of risk, as I don't have to tell you, but maybe you can actually articulate for us what the risk is when you have a BLS run report trying to describe why the ALS provider didn't ALS that patient. What are your thoughts on that?
Well, my thoughts are twofold. Number one is the EMS regulatory agency, the oversight, the complaint that goes to, in Massachusetts, it's own EMS, but whatever the state analog is, that's number one. And that's and that comes with it, the ever increasing concentric circle of, whatever the parade of horribles where they dissect and dice and they do a postmortem on the call, your policies, your procedures, why did this happen? And that's, Paul, with or without something negative happening to the patient. So government agency involvement, that's number one. Number two is obviously potential colorable claims for negligence. We sort of in EMS, we float under this simple negligence versus gross negligence, and it's got to rise to the level of gross negligence before a claim can come forward, that type of thing. But it's getting a lot easier for that statutory immunity to be undercut. So, a very important topic. There's a lot of risk, a lot of holes in the Swiss cheese that we can fill, and we've been doing that through teaching, coaching, and
Yeah.
mentoring. We've
Right.
been coaching up and reducing risk to our client EMS agencies.
Yeah. So normally the conversation goes something like this when you bring it to the paramedic's point of view, to the paramedic for a review from a QA perspective. And we meet with the provider and say, hey, how come you didn't ALS this? We get, a variety of answers. Most of them revolve around, well, they didn't need me in some fashion.
Yeah.
And often when they verbally give us their supportive documentation, right, verbal documentation, it's, well, his chest pain wasn't cardiac, and here's why I thought that, and that sort of thing. But there's nothing in the record supporting that, the official record for the paramedic. So if a review of this happens a year or 2 years from now or 6 months from now from OEMS or from a legal perspective, that provider's never going to remember the assessment stuff they did that negated the need for ALS for that particular patient. Let me give you an example. We did a call a number of years back, and I really love this for illustrative purposes because it's so clear. It was a PB crew that responded to a patient who took several swigs from a bottle of NyQuil. So they drank about half the bottle. The bottles are whatever, 4, 6, 8 ounces or something like that. And they swig down half of that. So the crew shows up, patient's alert, oriented, talking, vitals are all stable. It's a young person, no medical history, pretty clear cut looking, I can triage this safely to the BLS guy kind of thing, or at least it appeared to be. So the ALS provider said to the EMT, you can handle this, right? And the EMT, and I say this, a little bit tongue in cheek because, providers do this frequently where they don't want to do an ALS call, but they don't want the BLS person to give them pushback. So they phrase it in terms like, you can handle this, right? Or you don't mind taking this, do you? kind of talk. And then 99% of the times the EMT doesn't want to challenge the medic. So they're going to say yes. Even if the patient's dead, they're going to say, oh yeah, I can handle it, because they're not going to want to. So, that alone is a fault line in the dynamic of the downgrading a patient type of thing. So anyway, the paramedic will say that to the EMT. The EMT says, sure. He took the patient. The EMT gets to the hospital, writes up his report. It comes to QA, reread the report. The report says that en route to the hospital, the patient became obtunded and remained that way throughout the rest of the transport to arrival at the hospital. So, of course, the red flags all go up. So this guy took a significant, possibly a significant amount of NyQuil. There's all sorts of active medications in NyQuil. And, bad things can potentially happen if you take enough of it. So, the auditor scored it as a 3 or 4, medium or high probability for an adverse outcome. I went to the medical director. They said, yeah, I can't believe you guys BLS this. And they hand it off to me and say, okay, go talk to the paramedic about this one. So paramedic actually is a pretty good paramedic, responsible guy, a decent provider overall, not someone who normally just turfs things. So I said to him, hey, what happened on this call? And he says that the patient never became obtunded. In fact, when I backed backed the ambulance up to the doors of the ER, opened up the 2 back doors, I tapped the guy's foot and the patient aroused, and I said, hey, how you doing? And he said, I'm doing fine. He was sleepy because that's what NyQuil does to you. It makes you sleepy.
Right.
Okay, that's a very different presentation than an obtunded patient. So as it turns out, the EMT used a poor choice of words in describing that patient. And wrote the report as he saw fit, as he thought, he was writing a good report. And now that's the medical record, right? So without an addendum or a downgrade note or some sort of documentation to present the paramedic's point of view on that call, the official record is he let an obtunded patient go to the hospital without intervening. So now it also raised questions about why the EMT didn't do anything for the patient, right? So did you notify the paramedic up front? No, I did not. Did you do anything for the patient? No, I didn't. Why did you not? Well, he was easily arousable by just shaking him. Okay, so he wasn't obtunded. So we get into that whole dynamic. The EMT just used a poor choice of words, which is not uncommon. It happens fairly frequently, right? So the EMT has a certain level of knowledge and training and whatnot. They often don't get a lot of coaching and love from the QA department to help them with their diagnostic skills, their documentation skills, and those types of things. So they don't get a lot of feedback oftentimes to help them to bolster both their documentation and their patient care. So that agency, had a number of those types of calls, as every agency does, because it's a practice to downgrade patients in that system. And medical direction finally came to the realization that they probably should have a policy for enforcing a downgrade note with that particular agency, as we're seeing with a lot of other agencies that we work with. More and more medical directors are saying, I need the paramedic's point of view on these calls. And that's what we're here to talk about today, is the essence of the downgrade note.
Yeah, so in this particular, it kind of irritates me from the BLS perspective, because this is the thing. All right, so the paramedic triages to BLS a triageable patient by all accounts from the paramedic. That means the patient wasn't obtunded when the paramedic arrived. The patient becomes obtunded during the transport. Obviously, it had to happen that way. So why didn't the EMT call for the paramedics again?
Well, yeah, that was the case. That's, as I mentioned a bit earlier, is that the question for him is, how come he didn't call? Now, remember, this is a PB crew, so all he had to do was lean forward to the cab of the ambulance and say, hey, this patient went downhill, pull over, right? So, and he didn't do that. And it was because when I asked the EMT about it, he said, well, he was easily arousable. When I would just shake his shoulder and he would wake up. So he didn't believe the patient. He just picked a bad word, right, to document with. He didn't really know the definition of obtunded, and he used it inappropriately.
So the paramedic was driving and the EMT was in the back of the truck?
Yeah.
Right.
In this particular case,
all those other issues.
There's other stuff. Right.
All right. But the point is this. If you're a paramedic and you triage and you don't provide some kind of account for what you observed in a rationale for triaging to a lower level of care, you're relying on that lower level of care to cover your ass.
Bingo. So you're sitting in a... Go ahead. Sorry.
Yeah. No. So, again, it comes back to Clint Eastwood, right? Mm-hmm. Do you feel lucky, punk?
Yeah.
And this is not the only time we've seen, fortunately in this particular case, nothing untoward or presumably happened to the NyQuil patient. But there have been other cases where there have been near misses and even some potential harm that may bust that statutory immunity for simple negligence.
Absolutely. And, a key component to this is when the paramedic showed up, perhaps the patient was downgradable and something untoward happened, that the patient had an unexpected turn for the worse after arrival at the hospital or en route or something along those lines. So if you don't have a downgrade note, you can't just defend yourself to say, but when I assessed them, they didn't have any of that stuff, and it transpired after, and whatever happened. So, it's just, it leaves you exposed, significantly exposed, which means the agency is exposed, right, to liability there potentially if something bad happens here. So the agency, it's in their interest to have a policy. Most agencies don't even have a policy. The ones that have some policies are either not enforced or they're sufficiently vague that people just either ignore them and feel that they get away with it, or they write something. We have, a couple of agencies actually with the verbiage. The policy itself is so poorly written that it, in effect, is useless. So one agency, basically, the EMT just has to write that the paramedic assessed the patient and deemed him safe to be BLS'd, and the EMT writes that note. But that doesn't really provide you the paramedic's point of view on what happened and clinically why it was safe for that patient to be downgraded in the first place.
Right. Yeah. No, it's part of a bigger issue because obviously these folks, when they come in for their orientation, that orientation isn't covering these key issues such as downgrading notes. They're not getting the appropriate teaching, coaching, and mentoring. Now, and there's the old adage, if it wasn't documented, it wasn't done. That's not entirely true. I get this case. I'm sending my private investigator out to meet with the EMT, meet with the paramedic, and we are getting affidavits signed under the pains and penalties of perjury by the paramedic as to actually what they did, and we attempt to introduce that in evidence, whether it be, and most of this stuff is an OEMS regulatory issue, but we have that documentation.
Right. And, in a lot of cases, memories get faulty the longer out from the call that you go. By
Well,
the time
that's
it
true
gets to a
too. Yeah,
lawyer, there's weeks or months,
yeah.
perhaps.
No, you got
And
to keep us
then
on
you have
speed
the
dial.
problem where the paramedic makes a claim. Well, the patient was alert and oriented when we got there, but the EMT doesn't recall it that way.
Right.
So you might have a discrepancy between the two. So the paramedic's best defense is to defend themselves, right? So
Yeah,
put in a downgrade note. So
absolutely.
uh, so now the question becomes what's a good downgrade note policy look like, right? What should that entail? And so really we're looking for the paramedic to address why the patient didn't need ALS based on the either assessment findings or the complaint that the patient had at the time. So enough documentation to support the clinical decision making that it was safe to downgrade this person. In some cases, you can't do that, right? We've had a number of calls, the chest pain calls, right? Those
Yeah.
little old guy involved in a relatively minor MVA. He's got a cardiac history and he's had an MI in the past. And,
Yeah.
the crew gets there and the patient says, yeah, the pain's across where the seatbelt went across my chest. That's where it is. And the paramedic says, oh, well, that's not cardiac. That's just a seatbelt. And without doing a 12 lead, without inquiring further with the patient, without doing further assessment, they kick it off to the BLS guy. The BLS guy treats the patient, takes him to the hospital, and then it becomes, hey, this person has had chest pain. He's elderly. He's got risk factors. He's got history. And you didn't do a more thorough assessment as to whether this is potentially cardiac or not cardiac, and maybe even work it up possibly. And a lot of paramedics don't understand that. You and I have caught crap for that. We've
Facebook,
online,
right?
on Facebook, right, with somebody saying that we just want everybody to get ALS, and that's clearly not the case. That's just an ignorant statement. But the fact is that if that patient has indications,
yeah, it was more along the lines of we have Ouija boards, magic 8 balls. We're clairvoyant. We can tell the
yeah,
difference between musculoskeletal
yeah.
versus
Yeah,
cardiac chest
right,
pain.
right,
You
yeah.
know,
And the fact is, you
uh,
can't. There's no reliable mechanism to make that
right.
determination in the field.
But let me ask you this: uh,
Yeah.
we're both retired paramedics. We have triaged patients in the past. We are not, we have not been immune to anything that we espouse on this show because we've been there.
Mhm.
Why do paramedics triage to BLS? Right? I mean,
Oh boy.
our psychology, emergency, flipping the bicarb
Yeah.
caps.
Yeah.
Why do we triage to BLS, Paul?
Yeah. Well, there's a variety of reasons. Many of them are legit or semi-legit, and some are less so. So, in some cases, providers, and I was just actually talking to somebody yesterday, a very experienced medic, working in a major system here in Massachusetts, and we're talking about, in urban systems where it's super busy, the providers are sometimes worried about the more important call, right? So a kid could be
Right.
choking on a grape, so I can't take this
Yep.
patient who might not be having
We've
cardiac
done that.
chest pain. So we've seen and done that back in the day, in the early days of EMS. We've worked in
Yep.
busy systems and we had to triage from the field. It really doesn't go that way anymore. Nowadays, one patient at a time. You take care of this
Yeah.
patient, you provide the needs, and let dispatch figure out where to get the resources. If you have a management structure that's telling you to do that, then that's on them, right? Management shouldn't be forcing you to BLS patients that should be getting ALS because you don't have the proper resources to do the job properly. And in some
Right.
cases, we see that. We have these busy systems where management, they're getting hammered. Response times are getting elongated, not meeting contractual response time obligations. So they're telling people, just do the obvious stuff and get them to the hospital quickly so you can have a
Right.
quick turnaround time and get to the next call. So that's a
Yeah.
systemic problem, right? That's a problem
Right.
that the system needs to resolve. That's complicated, difficult. But remember, if you're the paramedic on that call and you're BLSing this because you feel pressured to do so, then there's a lot of responsibility on you. If that patient goes south, everybody's going to be looking at you. It's going to be hard to say that, management doesn't want us to ALS people unless they really need it, kind of stuff. So,
Right.
some of it is system design issue. Sometimes it is the paramedic legitimately thought this patient could go safely BLS, but they had a clinical condition that by protocol, by the paramedic training, or by the medical director wishes they shouldn't have. And, QA is going to pick up on that and provide that feedback back to the provider. And then the most egregious example is lazy paramedics, right? Unfortunately, in our field, and we're EMS lifers, right? We've been involved in EMS our whole lives. We love EMS. We're here to help paramedics get better, and EMTs as well. EMTs, all field providers of all levels. We're here to help them get better. So we're not here to, bust on them. But the fact of the matter is, there are some folks who don't want to do the job. And so they find it easier to give the work to the BLS guy, so they don't have to treat and give report and write a patient report and all that sort of stuff. They can just drive to the hospital, and that's easy. So there's a spectrum of reasons why ALS providers sometimes do this. And part of the QA process is you kind of have to figure that out too, right? Understand the motivation. And that's true of any feedback that you do for any provider. Is you're not just there to say, hey, you should have ALS this guy. You're there to understand their motivation. What's their mindset? Why do they think the way they think? How do they think? And is there something wrong with that thinking that I can correct for them and help them with, so that they have a better frame of reference when they go out there and make these decisions? For the folks who are conscientious, they'll pick up on that and they'll correct behaviors. For the folks who are just trying to get out of doing ALS calls, you're just going to be hounding. They're going to feel like you're just hounding them, to do more work that they don't want to do in the first place. And again, that's got to be dealt with as well. So that's a good question. There's a lot of motivations there and a lot of different factors that come into making that decision.
Sounds like there are three broad buckets that I'm hearing. Obviously, laziness, that happens. Rationing of ALS care. We have more ALS units on the road than we did back in the 80s, in the 90s. But nonetheless, there are still not enough paramedics to take care of all of the ALS needs of a lot of these communities. So laziness,
especially nowadays,
rationing of EMS care, ALS care, and then the third bucket seems to be just a flat out lack of recognition that the patient is in fact under the protocol an ALS patient and shouldn't be triaged for ALS.
Right.
Yeah.
Yep.
All right.
That's
so
kind of sums it up.
So with that broad understanding of why it's being done, develop a policy, educate on the policy. There should be some internal monitoring to make sure that the policy is being adhered to. That should be in your internal everyday monitoring of EMS CQI. That should be on your list of things to do. And then obviously bring in a third-party company such as us, Gerard and Associates, to do that third-party unbiased auditing of that process, so you can get, as an agency, as a CQI chief, you can get feedback on how well you're doing. We come up with that GNA score.
Yeah. And, we hear that often, too, is that the in-house CQI process, which can be very good, right? If it's, you got a dedicated staff and they're skilled and whatnot, it can be done in-house, no doubt about that. But sometimes in-house providers bring their own biases to the process. So if you're a paramedic who likes to downgrade and feels that a downgrade note is just more paperwork for the paramedic and isn't necessary, then that's not something you're going to pay a lot of attention to and address until a patient, has a big problem. And then everybody wants to know why the paramedic who was there at some point in the call didn't step in. So, it sets off a chain of events oftentimes. Yeah. So ignoring it's probably not a good option.
And here's the GNA alert, if you will, that this issue, downgrading calls, ALS downgrading the BLS, it's on the radar screen of regulatory agencies. They are going out and they review your run reports, and they are looking specifically for these types of calls now. So a lot of opportunity to plug those holes in the Swiss cheese before the regulatory agencies do it for you. And those clients that we have, we got this covered. How do we have this thing covered for our clients?
Well, it's one of the things we do when we order the call, right? So we determine the crew configuration. We know the policies in terms of BLS folks dispatching ALS folks and when they should be doing it and that sort of thing. And so when our auditors screen, they're screening for, if the paramedics were on scene, did they assess the patient properly? Did they write a downgrade note? And does the
Yep.
downgrade note answer the questions that need to be answered? So sometimes the paramedics will write a sketchy downgrade note with simply something to the effect of, "Yep, I came, I saw, I checked them out, I left because everything was
Yeah.
good," and that's not good. So what we do is a lot of departments will ask us, when they want to develop a policy, what parameters should we put on this? And one of those is the providers need to be educated that the downgrade note needs to, at least at a minimum, address the reason that they felt that what the clinical decision making was, that the ALS provider felt that this patient who has a complaint that could perhaps necessitate ALS, or on assessment has some indications for ALS. You need to directly address those
Yeah.
issues. So, if you got a patient that you kicked off to the BLS guy and they got a pressure of 90, and they're complaining of feeling lightheaded and dizzy, that's usually an ALS
Right.
patient, right? Should get a line, maybe some fluid,
Yeah.
blah blah blah. So you want to address that in your narrative. So in this case, it's the patient's normal blood pressure, and the reason they feel dizzy is they have a history of vertigo, and it was triggered by their allergies, as it normally is, and whatever the indication was that you felt justify that downgrade, you need to articulate that so that the next person downstream who reads this report, whether it's QA, medical direction, or a lawyer, family members, if they call for the record, hospital people who are looking to see what happened pre-hospitally, all the folks who nowadays read reports that, in the old days, nobody read the report anyway. So you could write anything you want or not write anything at all, and nobody would ever pick up on it. But nowadays, a lot of people are reading these run reports. So they need to be complete, thorough, and accurate. So part of that, the parameters of it, is that it needs to address the reasonableness of the patient being downgraded with clinical justification. So that's the main thing in terms of the actual writing of it. The other piece that comes into play is, how should you effectuate a downgrade note or a triage to BLS note? And this is where it gets a little bit interesting, because there are a variety of ways that you can do it. Some agencies simply have the ALS provider at the bottom of the narrative put a postscript, downgrade note, and put their stuff, sign and date it, right? Paramedic Gerard at, 12 o'clock on, 10, 12, 21, whatever. And that way, you've got a proper thing. Others actually have a policy that you have a separate addendum written to the BLS report. And a third way to go about it is that the ALS provider writes their own full run report.
Right.
And there are pros and cons to either any of those ways. So one of the probably the biggest pushback that we see on the whole downgrade note policy is from the providers themselves, the ALS providers, because they're busy, especially if you're in a busy system. They're doing a lot of stuff. They get a lot of responsibility, and then when you kick off the call to the BLS guy, if you now have to write a report, a lot of providers provide pushback and say, if I got to do all that documentation, I might as well just bring the patient in myself, kind of thing.
Right.
Not really true, but it's an exaggeration. But you get their point, right? They now have to do more stuff. But it is what it is. You got to defend yourself, and you got to have the record accurate. So basically, if you're doing a full separate report as a separate responder, separate unit type of thing, you have to put in a lot of the demographics that are repetitive. So that's a little bit more cumbersome than if you just put a narrative at the bottom, an addendum narrative at the bottom of the BLS narrative with your stuff, where all the demographic information and all that sort of stuff has already been entered by the BLS provider. So it's a little bit more efficient in that manner. It's also a little easier if you put the downgrade note directly in the run report with the narrative. It's easy to match the two together, because it's not always easy to find the ALS downgrade note that accompanies the BLS run report, and that is dependent on your EPCR programs and how they collect their data and aggregate their data for matching those two reports. So sometimes that's a bit of a challenge. So again, different ways to do it, whatever works best for that agency. Do you have a preference, Kevin, on any of those three options? Do you think it's better that they just add a postscript note to the report? Is it better that they have a whole separate document? Does it depend on the system?
I'm almost positive that during COVID, when I had my renaissance, I went back on the road, it was impossible to close out that run report if it was triaged without that ALS provider signing off or something like that. I may be mistaken, but
Well, the issue is that's okay if you have a formal triage that calls formally triage, but if it's not,
yeah,
where the
right,
BLS provider is writing the full report and the paramedic just keeps his mouth shut, then it doesn't. They're not picking the triage to BLS component in the drop down, and that doesn't trigger the
yeah.
triage note portion, that type of thing.
Do I have a preference? No, my preference is as ALS providers that we don't rely on that BLS provider to submit that note, and we've seen this with documentation such that advised the paramedic that this wasn't the patient was suffering from angina,
Right.
triaged anyway, or something along those lines.
Right.
And,
Right.
this
Right.
this I mean, when you're running nuts and you're on your 10th call on an 8-hour shift, you're getting antsy by the end. So,
Right. Right.
um,
Yeah. No doubt about it.
so my
Yeah.
preference is don't let don't lose control of that report.
Hmm.
You own it. You're the ALS provider. It's going to come back to you. Uh, so make sure before that thing is submitted, that trip sheet is submitted, that you've reviewed it and you agree with what's documented, and that your input is
Yeah.
documented as well.
Yeah. There's another piece to this, right? To fill those holes in the Swiss cheese, as we often say, is that in order to write the downgrade note, the prudent thing to do would be for the paramedic to at least read the narrative that the BLS provider is so that they can add to and embellish the parts
Yeah.
that might be missing, as opposed to reiterating the parts that the BLS provider wrote. And that's a great opportunity for the ALS provider to coach and mentor the BLS provider on his or her documentation, right? So if the BLS provider wrote a word like obtunded for a patient who wasn't obtunded, then the paramedic has a great opportunity to say, hey, that's not technically correct. You probably should change that, so they can, help the BLS folks write more solid stories, and describe the patient more, and teach, coach, and mentor them, which is a good thing. So it does kind of have some additional benefits if it's done appropriately, and the ALS providers are taking it seriously in terms of making sure the record is correct. So if they're able to do that, then the medical record is going to be more complete to begin with. So now, remember, keep in mind too, and this comes up on occasion, for everything, there's always pros and cons, right? And what some paramedics take that to mean, to coach and mentor the BLS provider and their documentation and their assessment skills and whatnot, when reading the reports in order to write their downgrade note, is they think that means they can go back to the BLS guy and say, hey, don't put that, the patient got started getting sleepy after, because people are going to think that I should have ALS'd them. So don't mention that type of thing.
Right.
The run report needs to be a complete, thorough, and accurate representation of everything occurred on that call. Do not allow this to be an opportunity for paramedics to get EMTs to be fraudulent in their report writing. They should be there to coach and mentor them, to help them to strengthen their report, not to try to pressure them to write things that didn't happen, type
Right.
of thing. And if there's a disagreement,
What
that
do
should
you
be
mean by that?
discussed.
Well, so I'm thinking I'm thinking the leading question kind of thing. Like, yeah, you saw me take that blood pressure, right? That
Yeah,
kind of
yeah,
thing. Or,
yeah. Well, it's
yeah,
that, and it can
we
be
didn't
very
need to put the
subtle.
monitor on that patient. You agree with that,
Right,
right?
yeah, right, right. It can be, pretty specific, right? I don't say I put a monitor on, kind of stuff, right? That can be, but oftentimes it's a little bit more overt. Sometimes it's more just inferring something, and trying to get the EMT to go, oh, so I probably shouldn't say that, right? Right, wink, wink. So regardless of what, it should be an endeavor to get it right, to get the
Right. Yeah.
information accurate, correct, make sure all the players on the team saw stuff. If one player didn't see something on the team, that's time to bring it up, right? And we see
That's
this
right.
often where,
Yeah.
the ALS provider is saying, I did this cardiac arrest. I'm writing up on my run report. I gave 7 EPIs, and the EMT comes back and says, hey, I picked up 8 EPI boxes that I restocked in
Yeah.
the truck,
Yeah.
so it could just be faulty memory even on the ALS provider's part that the EMT can help with. It's a team effort. So use your team members the way they should be used. So,
Yeah.
we know that by regulation in most jurisdictions, the medical record is the responsibility of both providers on that call, or all providers who are on that call, quite frankly. But assuming it's a 2-person crew and no other responding resources, when that report is written, when your name goes on the report, you are in effect saying that you agree with everything that's documented in this report. So we often say to paramedics, hey, you should be proofreading your partner's report. Oh, and it doesn't even matter what your level of providership is. 2 partners on any truck, the alternate partner who is not the one writing a report should still proofread that run report and say, yeah, to my recollection, this is accurate, because you're attesting to that when your name goes on the report, even if your other partner is the one who's putting your name in the field as their co-partner kind of thing. So either way, you're responsible. So you probably should. Now, most providers don't want to do that and don't do that. Here on the downgrade note, it's another opportunity to reinforce that your partner
Right.
should be
Yeah.
proofreading this report before signing it. And the best way to go about your documentation is to have it proofread by your partner and make sure you guys are in agreement, and your partner's filling in gaps that you may have not recalled when you went to write the report. So
Yeah.
just good practice.
I agree with you. I mean, you and I worked many years together. I read every single and critiqued every single one of your run reports, corrected you on many occasions, and look where you are now.
God knows I needed it. So if
Yeah.
you hadn't done that, I would not have reached the heights that I have reached in my EMS career.
I mean, your
So
use of
thank you.
Now, this was all, we had to handwrite these things. So your use of semicolons, I thought, was pretty exquisite. But, you could bolster some things.
So yeah, it really just should be done. It doesn't take that much effort. It's just a quick read. Certainly the narrative component of the report, but ideally, you're looking through everything to make sure the vitals are legit and stuff like that. So, but this is another good reason for it.
Yeah, absolutely.
All right. So anything else we should chat about on this topic?
Well, I think to close this thing out, it all goes back to your mission, your vision, your organizational philosophy, embedding CQI into the mix as an everyday habit. The folks you gotta look after each other in the truck, read each other's run reports, make sure everything that's documented, everything that you do is in the best interest of the patient, is in the best interest of the crew on that truck, and is in the best interest of the organization. Don't put your organizations at risk. It is a high risk endeavor for a paramedic to turf a call to a BLS unit. There is that ever increasing concentric circle, that parade of horribles that we can reduce. And the other thing that we really haven't talked about is, when you're triaging a legitimate ALS patient to BLS for whatever the reason is, there's some monetary leakage. There's some money that, and that money, we don't like to talk about money as paramedics. We're out there for the patient, and there for the grace of God, go EMS. But the fact of the matter is, hourly wages are increasing, health insurance costs are increasing. We as an organization have to capture all of those charges, and legitimate leakage should be reduced as a matter of good business practice.
Yeah, absolutely. We have our return on investment calculator on our website at gerardassociates.com that people have been going and using, and sometimes I'll get calls and we'll discuss this. And every client or prospective client that I talk to, when I say you probably have some leakage in calls being triaged that shouldn't be, and every one of them nods their head and goes, yeah, that's probably happening. And the same with refusals, right? There are other categories of leakage. So if you're looking to bring in revenue for your department, go after those calls. It's good both from a patient care standpoint, and a revenue standpoint. So that's a win-win. And if you're trying to justify the dollars you need to do the job right, that's one way that you can potentially do it, right? To show up a management that, your estimation from doing a sampling of those calls represents X many dollars in calls that probably should have had ALS that didn't. And if you had more QA resources so that you could provide feedback to providers in a more timely and efficient way, then that we can use that money that we'll obtain from that purpose. So, there's a direct correlation between good patient care and a thorough, complete system that works the way it's supposed to be and maximizing your revenue. So QA doesn't have to be just a cost. It doesn't just have to be a money drain. It can actually help you to recoup dollars that you're probably losing, because in every system there is some degree of that going on.
Yeah, and those dollars needed to offset those double-digit increases in benefits and health insurance costs and fringe benefits.
Yeah, everybody's hurting.
Everybody's hurting. So we got to capture that money. All right.
Right.
Well, that is it on this topic. Thanks for listening. Hope you picked up a thing or two on traps for the unwary. This is a hot button issue. It's on the radar screen of regulatory agencies. Avoid tunnel vision. Stay vigilant. And remember, we're out there to help you. We can help your EMS agency reduce risk, showcase your quality patient care. Check us out at GerardAssociates.com. Paul, anything else to wrap it up?
GerardAssoc.com, my friend. So you're giving them a wrong email. GerardAssociates.com.
Oh, GerardAssociates.com.
Yeah, GerardAssoc. So, nope, that's it. You covered it well, as you always do. So thank you for taking your time, Kevin. I appreciate it. And be safe, and we'll talk soon.
All right. For Paul, I'm Kevin Kelly. Stay safe, stay in the fight, and Godspeed. On 5.